Pathophysiology of obstructive jaundice. Obstructive jaundice, also known as cholestatic jaundice, results from the interruption or obstruction of bile flow in the biliary system. The obstruction prevents bile, which contains bilirubin, from reaching the intestines, leading to an accumulation of bilirubin in the blood. This can occur due to intrahepatic or extrahepatic causes. Below is a detailed description of the pathophysiology. 1. Normal bilirubin metabolism. Hemoglobin breakdown. Red blood cells break down in the spleen, releasing hemoglobin, which is metabolized into heme and globin. Heme is further converted to biliverdin and then to unconjugated, indirect bilirubin. Transport to liver. Unconjugated bilirubin binds to albumin and is transported to the liver, where it undergoes conjugation by the enzyme UDP glucuronyl transferase to form conjugated, direct bilirubin. Excretion into bile. Conjugated bilirubin is water-soluble and is excreted into bile, which enters the duodenum for digestion and elimination. 2. Bile flow obstruction. When bile flow is obstructed, bilirubin cannot be effectively excreted into the intestines. This leads to accumulation of conjugated bilirubin. Conjugated bilirubin leaks into the bloodstream, increasing serum bilirubin levels. Decreased excretion. Less bilirubin reaches the intestines, leading to reduced formation of stercobilin, responsible for stool color, and urobilin, responsible for urine color. 3. Causes of obstruction. Obstruction can occur at various levels. Intrahepatic causes. Hepatocellular damage, e.g. viral hepatitis, alcoholic liver disease. Primary biliary cholangitis or primary sclerosing cholangitis. Extrahepatic causes. Gallstones blocking the common bile duct. Tumors, e.g. pancreatic or bile duct carcinoma. Strictures due to inflammation or surgery. Parasites, e.g. liver flukes. 4. Effects of obstruction. A. Bilirubin accumulation. Hyperbilirubinemia. Primarily conjugated bilirubin accumulates in the blood. Jaundice, yellow discoloration of skin, sclera, and mucous membranes. Dark urine, excess conjugated bilirubin is excreted by the kidneys. Pale stools, reduced stercobilin in stools. B. Bile salt retention. Pruritus. Bile salts accumulate in the skin, causing itching. Malabsorption of fats. Bile is necessary for fat digestion. Obstruction leads to steatorrhea, fatty stools, and deficiency of fat-soluble vitamins A, D, E, K. C. Cholangiocyte damage. Inflammation. Accumulation of bile causes bile duct inflammation, cholangitis, and fibrosis over time. Infection. Stasis of bile increases susceptibility to infections, ascending cholangitis. D. Systemic effects. Coagulopathy. Vitamin K deficiency leads to impaired synthesis of clotting factors 2, 7, 9X. Hepatic dysfunction. Chronic obstruction can cause secondary liver damage, progressing to biliary cirrhosis. 5. Complications. Ascending cholangitis, a life-threatening infection of the bile ducts due to bacterial overgrowth. Sepsis. Severe cases may lead to systemic infections. Biliary cirrhosis. Chronic obstruction can cause irreversible liver damage. 6. Diagnostic findings. Biochemical markers. Elevated conjugated bilirubin. Increased alkaline phosphatase ALP and gamma-glutamyl transferase GGT indicating bile duct injury. Imaging. Ultrasound, CT, or MRI may show dilated bile ducts or obstructions, e.g. gallstones, tumors. Liver biopsy may be needed to assess intrahepatic causes. Conclusion. Obstructive jaundice arises from disruption of bile flow, leading to systemic effects and complications due to bilirubin and bile salt accumulation. Timely diagnosis and treatment are essential to prevent irreversible liver damage and other complications.